Hello, in this video, I'm going to talk about scapular muscles. So muscles that attach to and move the scapula, aside from the ones that we've already covered. So we've already talked about several muscles that attach to and move the scapula, but that also cross the glenohumeral joint, or like levator scapula that goes up into the neck. So we've already talked about several, so these are the remaining muscles that we haven't discussed yet. All right, so starting with pectoralis minor. When we talked about glenohumeral muscles, we talked about pectoralis major, and we did not talk about pectoralis minor. That is because minor does not cross the glenohumeral joint, so it does not have action at the shoulder. Okay, I can't say that enough. Pec major has many actions at the glenohumeral joint. Pec minor does not have any actions at the glenohumeral joint because it does not attach to the humerus. It only attaches to the ribs, it originates at the ribs, and inserts in the coracoid process of the scapula. So it can move the ribs and the scapula. It cannot move the humerus, so it does not have actions at the glenohumeral joint. Okay, so because of its attachments, on the angle of the fiber, so we could see it all the way on the right on that picture, it's got like four pieces, 3 or 4 pieces that are coming from the ribs and then going at an upward angle up to the coracoid process. So when we think about the attachments of the muscle getting closer together, well, what would happen is the scapula would come to the side and a little bit around. So that would be abduction of the scapula as it's coming this way, and a little bit of protraction as it's kind of wrapping around. So it would do abduction and or protraction of the scapula. Also, if the scapula stays still and it pulls up on the ribs, it will assist in forced inhalation. And if the ribs are staying still and we're pulling down on the coracoid process of the scapula, that would cause downward rotation of the scapula. So remember, upward and downward rotation is named for the direction that the glenoid is going as it's rotating. So if we pull down on the coracoid process, that would be downward rotation, because down with the coracoid process is also down with the glenoid fossa. Okay, rhomboid major and minor are these muscles in the middle of our backs. It's deep to trapezius, which I believe we'll get to next. When we see left and right together, they look like this in the middle of the spine, shaped like a Christmas tree. Okay, so they're going from the spine's processes of the lower cervical and upper thoracic, and then angling down to that medial border of the scapula. So when origin and insertion get closer together, it's going to cause the scapulus to go up, that's elevation. It'll cause them to come together closer to the spine, that's adduction. And because they're pulling up at an angle, it will pull up on that medial and inferior part of the scapula, which causes downward rotation. Again, if we're pulling up on that medial part, the glenoid fossa would be going in a downward direction, which is downward rotation. Okay, trapezius is a very large muscle. The origin is all along that spine in the center there, and there's lots of different parts of the origin. We'll see that on the next slide. We'll talk about that a little bit. And then it converges and comes down together into the top of the shoulder. Okay, so trapezius does not cross the glenohumeral joint, so it does not have actions at the glenohumeral joint, but it does move the head and neck and the scapula. So just like some of our other muscles, we can break it up into different sections of fibers that have totally different actions. So the superior fibers, the ones coming up from the neck and down over on top of the shoulder, they're going to extend the head and cervical spine. So if bilaterally they contract, it's going to extend the neck and cervical spine. If we contract them unilaterally, so only on one side, it'll pull the head and neck down towards the shoulder. That's lateral flexion. It'll rotate the head and cervical spine to the opposite side because of its insertion, or because of its origin up at the back of the head. So it's at the back of the head coming down on top of the shoulder. So if it contracts and the origin and insertion get closer together, it's going to rotate the head to the opposite side. If the head stays still and it's pulling on the scapula, it will pull it up. That's elevation. Or if it's pulling up on top here, on top of the shoulder, it will lift up like that. That's upward rotation. Okay, so it'll pull up on the scapula and upward rotation. The middle fibers are the ones right in the center that are just going straight across. They're in this medial lateral direction here. So their job is to adduct and stabilize the scapula. So they adduct along with the rhomboids. Okay, and then the inferior fibers, the ones that are all the way inferior here and going upward at an angle towards the scapula, those are the inferior fibers. And if they pull, they could pull down, that would be depression. And because they're pulling on the inferior medial border of the scapula, they will also contribute to that upward rotation of the scapula. Okay, so the superior and inferior fibers act as a force couple, which we'll talk about in future lectures, that are both pulling on the scapula from opposite directions to cause it to upwardly rotate. It's sort of like how when you got two hands on the steering wheel, your hands, if you're turning, your hands are going in opposite directions, but causing the wheel or causing your steering wheel to turn in the same direction. So they're acting together to turn the wheel, even though your hands are going in opposite ways. And that's exactly what your superior and inferior fibers are doing to the scapula. They're pulling in opposite ways on the scapula to both cause upward rotation. So we're causing the steering wheel to turn in the same direction. Okay, so here's the origin and insertion of trapezius. So again, the origin includes the external occipital protuberance. That's that big bump in the middle of the back of your skull. The superior nuchal line is the ridge that projects laterally from the external occipital protuberance. And then the spinous processes all the way down the spine, or down at least the lower cervical and thoracic spine. And then it inserts into the lateral third of the clavicle, the acromion, and the spine of the scapula, which should sound familiar. That insertion of the trapezius is exactly the same as the origin of deltoid. Okay, so they share an attachment, but for trapezius, that's its insertion. For deltoid, that's its origin. So the two muscles do not overlap. One starts where the other ends. Okay, serratus anterior gets its name serratus, like a serrated edge or a serrated knife, because it has that sort of zigzag appearance on the anterior side. So this muscle, its origin is the surfaces of the upper 8 or 9 ribs. So its origin is the ribs kind of on the anterior side. And then it wraps around to the back of the body and it inserts on the anterior surface of the medial border of the scapula. So this muscle is going between the scapula and the rib cage. It's going anterior to the scapula and inserting on its medial border. So when the origin and insertion get closer together, one thing that it does is help hold that medial border strongly on the back of the rib cage there. So if someone has a serratus anterior that is injured, or the nerve might be damaged, or it's weak for whatever reason, one thing that happens is you see winged scapulas. That's when the scapulas are kind of peeling off the back of the body. Like when you can get your hand really far under there, and if you observe their posture and you see there's kind of space and the scapulas are sticking out, those are winged scapulas. And that happens because serratus anterior is, for whatever reason, not producing enough force and holding the medial borders of the scapulas onto the rib cage. So strengthening serratus anterior is very effective for correcting winged scapulas. So that's one thing it does. It holds the medial border of the scapula against the rib cage. It also abducts the scapula, or abducts and or protracts the scapula. So if the rib stays stationary and we're pulling on the medial border, it's going to pull the scapulas away from the spine, away from the midline, and start to wrap around a little bit. Okay, so they're going to protract or abduct the scapulas. Also, because they're angled sort of downward, it will pull down on the scapulas. That's depression. And if the scapulas stay fixed, it will help lift up on the ribs during forced inhalation. And I mentioned this in the abdominal video, but where you see that serrated edge of serratus anterior, it interdigitates with external oblique. So external oblique, you can sort of visualize in this picture as coming up from the abdomen and then interdigitating, sort of connecting with serratus anterior that's coming from the posterior part of the body. Okay, that's all I have for you in this video. Let me stop recording here. So thank you for watching, and I'll see you for the next one. Bye.